The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and welcome to another Wednesday Safe and Calm webinar. This is Deanna Mitchell with Leading Age Michigan. A lot has happened here in Michigan again this week, and unfortunately the daily COVID case rate keeps rising. And this is all occurring as we begin the cold weather and the holiday season on top of it. So we know that everyone has their fair share of challenges these days. Just a brief note before we move on, I want to specifically remind everyone, including myself, that we cannot share wage information on our listservs. There are antitrust and other rules about that, so please ignore the request we put out yesterday for some wage information. And also, I want to remind everyone that we send out quite a bit of information out on our listservs, and if you are not signed up for your on the listservs, please shoot us an email and let us know, because in between times and at off hours, sometimes when the department issues something late in the day, we will send it out in the listserv rather than in a member update. So just a reminder about that as well. So today, we're going to be spending most of our time looking at the two orders that were issued on Sunday and Monday from the Department of Health and Human Services here in Michigan. One was on gatherings and one is on nursing home cohorting. And of course, we will end with a few short notices and updates specific to nursing homes, but we think that that information will be helpful to others as well. So we're going to start, obviously, with the situation update briefly, noting that there's really nothing going on with the legislature. So we're kind of skipping that section this morning. Our first slide in terms of our look at data is our routine update of the Michigan 7-day rolling average of new cases. And of course, over the last week, it is again, it continued to rise. This data is current as of November 16. And it's important also to know that over the weekend, we peaked with the largest number of cases to date. It went as high as 8,516. And you can't see that on the slide. And the reason for that is because this is always a 7-day rolling average. So, you know, it smooths those peaks out. But we all know that cases are rising sharply across the state, and you can see that in the slide here. This next slide is, again, the 7-day rolling average of Michigan daily deaths. We have experienced a bit of an increase since a week ago on November 11, but you can always also, see that the number of deaths has flattened out over the past few days, even as the caseload increases. It is true that both of the sets of data for daily caseload and for deaths sometimes come in batches, so you'll see peaks and valleys in it. But it is more likely to come in batches for the death data. So it's submitted in groups. So we'll have to see if this flattening will hold over the next few times, and if it's really representative of a decrease of death or if it's simply because of the timing of reporting. Here is the department data on statewide test positivity rates. Their published data does only go through November 11. But you can see from October 1 onward, there's a steady increase in the proportion of tests that are positive. This next graphic is something we started last week, and basically in response to the fact that the state now publishes new cases for nursing homes in aggregate, at least. This chart only had 2 data points last week, and it doesn't look a whole lot different this week, but it's because the increase was pretty steady. So I included the raw numbers of new weekly cases at the bottom of the chart itself. And at this point, 100% of nursing homes are reporting, and nursing homes in the week preceding 11/16 had 719 new COVID cases. For HFAs, you can see a steep incline, but a lot of that has to do with increased reporting. As of Monday, 68% of HFAs were reporting. However, it is probably also a sign of an actual increase in the numbers of cases in HFAs. Since last week, only 63% of HFAs were reporting. So that isn't that great of an incline in the number reporting. And you can see that they had 185 new cases in the week preceding to 11/16. For AFCs, the same thing holds true, although the number of groups reporting is higher. I think it was 38% last week. Now it's up to 45%. And you can see with that number of AFCs reporting, they experienced 87 new cases in the past. So a quick look at the map will show that the entire map is now purple. And if you look at the county levels, the link that is off the My Safe Start map website, every single county in the state of Michigan is now level E, which is the highest level you can be. So there is no good news here. And the reported positivity rates and new cases as identified by the state are also on the slide. So we're going to start this morning with our resources and guidance update with what the governor's team is calling a 3-week pause. So that 3-week pause has caused an awful lot of stress for the governor. She has added additional restrictions to most public gatherings, looking at the data, similar to what we just did. It allows social gatherings through the Thanksgiving holidays and for up to 10 persons within 2 household families. And this order will be effective through December 8th. The link is right here. We're not really going to go through the details of this new order, but they have issued 3 different infographics to summarize the requirements, which might be helpful for you and your staff. This one lists the types of organizations and gatherings that are currently open and those that are closed. Right now, Director Gordon at the department is currently facing several lawsuits from portions of the restaurant industry for closing down indoor restaurants. So we know this is still controversial, but the department is responding to the high caseload that is surrounding and currently in every county in Michigan. This next infographic provides guidance for social gatherings. They advise that everyone should pick only one family to see during the next 3 weeks, and they're calling that a pod. They are advising to choose one that is being very careful in terms of COVID precautions. They want to limit the duration of time that people are visiting together indoors. And the expectation is that everyone should wear a mask except when eating, stay 6 feet apart, etc. All of the normal precautions as well, but to be very limited in the people that you're interacting with over the next 3 weeks, considering the amount of transmission that's going on in the community. And this last infographic has some additional rules for pods. It talks about how to communicate and set up your pod and what some of the thinking is in regard to that. So these are fairly good infographics that at least describe what the expectations are. So let's stop for questions, see if there are any questions about any of that to date.
All right, thank you very much, Deanna. Before we get into any questions, each year Leading Age Michigan honors individuals and groups who embody excellence in leadership, care, and service innovation, and who have made outstanding contributions to their communities in the field of long-term care. It is always a time of celebration and laughter. Join us on Wednesday, December 9th for a free live streaming event at the Leading Age Michigan Facebook page beginning at 1 p.m. Eastern Standard Time and lasting until 4 p.m. This year, we'll be virtually acknowledging our many award winners, and we'll be joined by two of Michigan's greatest resources, Monica Levin and Tim Cusack. We are excited to be able to acknowledge our many award winners and celebrate one another as well as we do our best during these very challenging times. Leading Age Michigan would also like to thank our many dedicated business partners who continue to support our members, their staff, and the association in everything we do. So we would like to thank Omnicare and our main contact over there, Matthew Garlick. We'd also like to thank Andy McLeod over at GMB. We'd like to thank Kim Murphy and Carrie Hensel over at Therapy Management. Sheila Ralston at Creative Dining, and of course, Tom Myers over at Ziegler. Together with our sponsors, we know by working together and offering support to one another, we can overcome anything. Please celebrate one another with us. We will have more information coming up on this shortly, as well as a RSVP/registration is what I would call it, and we should have all of that up hopefully by either the end of the week or at the beginning of next, and we can start getting you a little bit more information on that. We do have one question. Any best practices to get testing done 2 times weekly within the increased positivity rates?
I'm not sure exactly the context of that question. I don't know if you're talking about if you're doing it twice weekly because of an outbreak, or if because you're in a red area. There are a lot of counties right now that are in the CMS red areas and would have to test twice weekly. If it's in terms of timing, I always assume that, every 3 days and then every 4 days works. If you're having an outbreak and you're doing twice a week testing, the recommendation from the CDC is that you actually test about every 3 days for the first couple weeks. If it's a surprise, I would refer you to the department, MDHHS. They have testing guidance, and you can request more testing supplies from them. If it's anything beyond that, please just shoot us an email and we'll try and work through that.
All right, it looks like that was our only question, so we can move on.
Okay, so we're going to start with CDC updates this morning. There have been several. They're fairly interesting, if not directly related to absolutely everybody. The first is a CDC toolkit for long-term care facilities, and this was originally designed for influenza, but they suggest that it be used to educate staff on the need for vaccinations for both influenza and COVID. Obviously, the goal is to increase the number of personnel who are currently vaccinated, and they do specifically say that although it's for influenza, it is also very useful for COVID vaccination information as well. I think that they may have updated it for that, and the link for that tool is on this slide. So another CDC update is about community-related exposures for healthcare personnel, and some of this seems self-evident to me, but they did update the guidance to include information for healthcare personnel who may have been excluded from work because of recent exposure. Apparently, there's been some issues with staff not understanding that exclusion from work doesn't mean that you don't have to stay at home and quarantine yourself. So it really talks about the concerns that these persons also isolate themselves at home and must stay away from the overall community as well as the work environment. This is especially important now, for there are persons who actually may be working in COVID positive units in hospitals and other facilities who have tested positive but are asymptomatic. If you look at the CDC guidance for optimizing staff options, when you're in the middle of a surge and you're having a staffing crisis, that is one of the options, to use asymptomatic COVID positive staff to care for COVID positive residents or patients. So many healthcare workers right now are continuing to work through the illness in areas where there are extreme shortages. And we know that there are a couple in hospitals in Michigan. And so they're already caring for COVID positive persons. However, as would be expected, when off duty, they must absolutely quarantine at home. The CDC this week also issued an update on its coronavirus treatment acceleration plan. Note that this is for treatment, and it's not really reflective of any work on prevention or vaccinations, etc., vaccines. At this point, there are 270 different treatments in late-stage trials. Only 5 are approved for emergency use, and 1 has been fully approved, and I believe that's remdesivir. The link for that, for anyone who's interested to read on the treatment stages, the link is at the bottom of the slide. This week, the FDA also put out a warning that currently there are no over-the-counter approved treatments either for flu or COVID. Of course, there are medications that reduce symptoms that are over-the-counter and appropriate. But there apparently have been some companies who have attempted to sell treatment products marked that way for COVID on the internet, and these groups are currently receiving warning letters. And so if you want more information about that, again, the link is on the bottom of the slide. So, also this past week, Leading Age has issued a toolkit for member providers, and it is for member providers only, called the Pandemic Playbook. It is filled with ideas and best practices for serving older adults during this pandemic. I have actually not had time to look at it yet, but wanted to ensure you all had it as a potential resource. And if you want to take a look at it, the link is on the bottom of the page. So from this point on, we're really going to be talking about things that are directly related to nursing home only, but others might find the discussion about the care and recovery centers and the COVID relief facilities important. Technically, the department, MDHHS, has already responded to the legislative requirements recently passed for care and recovery centers. They already put out guidance. These are the entities designated to serve COVID positive residents who are in need of post-acute or nursing home level of care, and they are meant to eventually replace all of the regional hubs. Yesterday, the department made a small tweak to the guidance for those care and recovery centers, those hub replacement centers, that basically aligns their rules closer to what was defined in the law. They added criteria that one of the pieces is that you had to hold a 3-star in staffing in order to be a care and recovery center. Now they're saying that you could have a overall 3-star rating or higher, and that would help meet that criteria as well. So now with this, they have issued the second part of the guidance, and they're calling these CRs, COVID relief facilities. And I'm struggling with that a little bit because we have CRCs now, care and recovery centers that replace the hubs, and now we have COVID relief facilities, which are your nursing homes who are allowed to have a dedicated unit. So the words, the acronyms at least, are very similar and can be confusing. There are 2 sets of possibilities for people who want, for facilities who want to, 1, keep their current COVID residents and readmissions to their facility from a hospital or wherever who may be COVID positive. And then there's another pathway for facilities who actually want to admit new residents who may be COVID positive. And we're going to talk about both of those. So there has been a lot of confusion and a lot of questions about this guidance, and there are pieces that we had to think hard about as well. The primary policy document is part of the difficulty. It is MSA 2073. And this policy is a direct response to Senate Bill 1094. Originally, we had hoped that the law would directly represent the findings from the governor's task force. But the bill sponsors in the legislature actually wanted to shut down all COVID positive persons in all nursing homes, which would have been a logistical nightmare. And all of our members would have had to make their residents move to other facilities, some of which would have been far away. And some of these facilities are not necessarily high quality facilities or necessarily pleasant places to be. So although this is another challenge and another burden for providers, we did work with the department, and we felt that they did a fairly good job at walking the fine line between the epidemiologists and some of the stakeholders and legislators who wanted to move all COVID residents out of the nursing homes, and our members who also just want to be able to continue to serve their frail residents. So the rules give each an option. So as a member, you can have an option to do either. And at the same time, the department hoped to raise some of the standards for COVID care in general. There's been some confusion about two things that the department does, and this is what I was alluding to earlier. So although it issued the guidance under Medicaid, some of our members thought that if they weren't a Medicaid facility or for non-Medicaid patients, they would not have to apply this rule, and that is not the case. These rules apply to all entities licensed as nursing homes in Michigan. And additionally, sometimes the department uses the acronym SNF, SNF, for a nursing home. And that does not mean that they're only referring to facilities that are certified for post-acute care. So those are two pieces of confusion that we've identified specifically this week. And so we want to make sure that everyone knows that most times when the department says SNF, they mean nursing home. And when they put out this guidance under Medicaid, they're sending it to Medicaid facilities, but it applies to every nursing home in Michigan. So, in order to participate and be designated as a COVID relief center at all, first you must have an area that you can dedicate to that, and that would be no surprise to anybody. You can use the end of a hall if you want, as long as you meet all the other physical criteria. And in fact, none of the remaining general criteria are new or would be a surprise. You have to have dedicated staff, and we all know that that's a big challenge. You have to have sufficient PPE and adequate testing capacity. And this is the minimum criteria if you want to retain your own COVID positive residents or take your own residents back from the hospital. If you want to readmit new residents, you have to meet some additional criteria. You must have at least a staffing rating of 2 using the CMS 5-star scale. You must not be a red hand facility. We did talk to the department about that. They really didn't have much of a response other than the fact that they noted that this is only a criteria if you want to readmit new residents. But I'm sure that we will continue the conversations about that because we know some of these citations are fairly low-level citations. You must have had some COVID experience. So if you want to admit new residents, you've had to have some experience with COVID in the past. And you also must have an infection preventionist who has taken and become certified via the CDC training for that. In terms of overall facility physical standards, any facility who serves COVID positive residents, so all of this criteria are for any of the designated COVID relief facilities, whether you're just retaining or whether or not you're admitting new. You have to, again, have that separate area. You have to have signage that clearly identifies the unit. You have to ensure that there's no entry or pathways through that area for other residents, no shared bathroom facilities with non-COVID residents, etc. Additionally, there's a preference for facilities who have a dedicated staff entry, an internal break area, and staff restrooms. But if that's not possible, given your physical layout, you have to identify how you will maintain infection control standards. And of course, you must have a dedicated donning and doffing area at the entrance and exit. That's going to be required by the surveyors as well, with separate areas for clean and used PPE. Staff must be working solely in the dedicated units, and facilities have to ensure that other care and treatment to serve the resident are available while in the dedicated unit. In other words, if the person has post-acute or long-term care requirements, all of those things must be addressed while in the dedicated unit as well. The department is requiring that the CNA staffing ratio, while they didn't identify what it has to be, they said it must be appropriate based on the number of residents that you could hold in the unit. So a lot of this, it's not really a surprise. There are also some basic training requirements, and all staff have to be trained. So anyone who is considered dedicated staff for that unit has to be trained. Here is where the CDC would recommend that you not allow all these types of personnel into the unit, but you train some of these persons, you cross-train them actually, to serve in additional roles as needed. Also, facilities must have a policy to ensure that they're monitoring staff compliance with infection control standards really on an ongoing basis. And again, as expected, you have to have an adequate amount of PPE for the unit, testing compliance, and specific staff and resident screening procedures and tools. In addition, any facility approved to serve COVID positive persons must have a communication plan. And that plan has to address the presence of COVID in your facility. It has to explain your plan and program to residents, families, and staff. And that would include how you will maintain both safety and resident support, along with staff support during the pandemic. How you will communicate updates, how you will focus on virtual visitation for persons in the unit. And if you are admitting new residents, there's an expectation about how you will communicate and work with your local hospital in terms of bed availability and supporting the local referring hospitals who will be looking for placements. So this is a big issue for the state. The state really continues to have concerns, especially right now, with the ability to move patients out of the hospitals when it's appropriate and finding placement for them. So having a plan to work with your local hospital if you intend to take these admissions is really important to the state. So facilities who want to admit new residents who are COVID positive can only do so under certain rules. And remember that there are only I think 3 CRCs right now, and we anticipate that there's not going to be a flood of them across the state. So facilities who want to admit new residents to their facility specifically can do so if there is no CRC, CRC within 25 miles. If there is no local CRC with any capacity, and a lot of them often don't have the ability to take patients right now. If the resident has special needs that cannot be met by the CRC, we all know that there are different levels of care at different facilities, and if a resident has needs that you can meet but the CRC cannot, that would be a reason that you could admit them. And I think this is an important piece. It has to do with their preferences, and that's why I highlighted it here. The resident or legal guardian prefers that the resident be admitted to your facility. That's enough to get them into your facility rather than them having to go to a CRC. Otherwise, if you want to admit a new COVID positive resident, but you cannot meet any of the above exception criteria, in order to do that, you have to request approval from the department, and the email address for that is listed on the slide. And of course, you know, we're in the middle of a major surge that could very well get worse. So the department understands that these rules could constrain appropriate discharges from hospitals, and there could be a lot of issues with placement moving forward. So they are reserving the right to issue any additional provisions to expand the possibilities to become a COVID relief facility, or how in the process in which facility can accept residents. So they're going to reserve those rights in case they need to move forward very quickly if there are emergencies. So any facility that is admitting a new resident, so this is someone who hasn't been in your facility, at least not recently, who is COVID positive, you pretty much have to ensure that you've documented the circumstances that allowed you to do that, which means how the criteria that we just talked about was met. If the person had special needs, you might consider including the care plan that identified that, how you might have met the distance exception or the CRC capacity exception. And also you're asked to document your communications with the local care and recovery center about any of those things when you have made the decision to admit a new resident with COVID. So these rules are in effect as of December 1. If you do not have a designation as a COVID relief facility at that time, you must transfer COVID positive residents to some alternate location as soon as practicable. That could be one of the new care and recovery centers. It could be another nursing home who has approval. There is some talk about increasing the number of hospital swing beds that might be available as well in the future, but you're going to have to start working to transfer those persons if you don't have a designation at, as of December 1. But if you do have an application in process by that time, you can keep current COVID positive residents while you're waiting for approval, but you can't admit new COVID positive persons until you actually get approval. So you don't have to move your residents out if it's not your intention to do so right away, as long as you have an application in by the end of the day, December 1. They note that they intend to send approvals via email. And for providers who have any questions about any of this process, there is a provider support email address noted here for you to use. So the application process is SurveyMonkey, and I did try to access it to determine how much information is actually required, but you have to fill it out piece by piece in order to move through it, so I gave up on that around, slide 3. We have asked the department to provide a document that identifies all the necessary information, but they responded to us that they're having some logistical problems with that, and they're not able to do it at this time, but they're working on it. And to me, in my head, I'm going, well, there must have been some source document to create these questions. I'm not sure why it's so hard, but they're telling us that it's just too difficult to do at this time. If you are applying to retain residents, the approval process is expected to take several days only. But if you are applying to admit new residents, and the survey does ask you what your intention is in terms of these two categories. So if you want to admit these new residents, it might be 1 to 2 weeks before you hear from them. And it's important to note here that if you do not want to have COVID positive persons in your facility at all, and we know that there are some facilities in that category, you simply don't have to apply at all. But that means that when someone becomes COVID positive in your facility, you're going to have to transfer them. For the application itself, you have to complete the SurveyMonkey form, attach a floor plan, your communications plan, the certificate from the training, the CDC training for your infection preventionist. You have to also include your resident and staff screening procedure, an example of your screening tool. So that pretty much includes everything that you're going to have to send in order to get an approval. So we just have a few more slides, including the updates, some upcoming updates about NHSN, and then we'll take some questions about all of this piece. There are some recent changes that CMS and CDC are anticipating to the reporting requirements. And before we get started down this path, we want to remind everyone that we here at Leading Age Michigan cannot be experts in this complicated reporting process. We are not providers, and because of that, we don't have access to it on a daily basis. We don't have daily experience with understanding the details and the challenges. So we continue to suggest that if you have questions about reporting requirements for NHSN and how you fill out what where, we do suggest you contact them. But we are aware of some changes that they plan to make in the next few days, actually. So these changes are occurring in 2 sections. The section called Resident Impact and Facility Capacity, and the second section is Staff and Personnel Impact. The CDC hopes to finalize these changes by the end of November, but it could be much sooner than that as well. So basically, they're changing some of the data levels and they're adding elements. The label that says confirmed tests is going to be changed to positive tests, and they're going to include some additional elements here. Whether or not this person, the number of people with a positive test using antigen-only testing, a positive test using PCR-only testing, a positive antigen test followed by a positive PCR test, any other combination with at least one positive test result. And they do want to remind everyone also that when you're talking about confirmatory tests, that you can only call it confirmatory if it's been conducted within 48 hours. Otherwise, it is not considered that way. But it's just more detail about how to identify the kinds of tests that you've been using to identify a positive COVID resident. There's also some additional elements about reinfections. There's some additional information that will be required to identify whether they were positive following up test results when they were asymptomatic, or positive test results from when they were symptomatic. And they are also looking at different definitions for death, total deaths. We have heard that, and we don't have a lot of detail on this yet, but we've heard that they are trying to clarify the death reporting because they've noted a lot of errors in how deaths are reported here. So that's a piece that they're trying to make more clear. We do anticipate that they're going to put out training for this shortly. We're just giving you some ideas of what's coming down the road. One of the other things that they're actually adding, and this is probably in anticipation of flu season, is they're adding an element that includes non-COVID respiratory illness. They want to look at the rates of influenza and persons with respiratory illness that might not be either COVID or influenza. And they also want to capture persons who may have both viruses simultaneously. So these are new elements that they're adding to the system. They also have distinguished whether testing information is really conducted, whether the testing is actually conducted by point of care testing or lab testing. And of course, they're capturing turnaround times for each and the ability to obtain supplies. So that really completes our nursing home updates. We did receive a lot of questions about the COVID relief facilities and CRCs yesterday. There may be some this morning as well. So let's open up to some Q&A, Blake.
All right, thank you very much, Deanna. We do have a list of questions here, so I'm just going to hop right into those. Forewarning, this first one is kind of long. If we have COVID positive residents that are in a separate unit but cannot provide dedicated staff, and our policy is to send them out whenever possible, but cannot due to no CRCs, CRs, or hubs, nor any hospital beds available, what are we supposed to do? Any ideas or suggestions? We have talked to several others and are not alone in this scenario.
Oh, that's true. I think, we're going to continue to find some challenges with placing COVID positive residents, especially as the caseload in the facilities rise, and actually, caseload is rising everywhere. It's always been a question that there may not be any available options. And I think the most important thing is to let your local health department or local healthcare coalition know that, and MDHHS, and document that you're attempting to move these persons. Obviously, if there's no safe place for them to go, there's really not a whole lot more you can do. If these processes and systems don't work for you. But I do think that it is best to do what you can to transfer these persons, document that, and then also try to create as safe an environment as you can, given the limitations in your facility.
If we cannot meet the CR criteria but have nowhere else to discharge our COVID positive residents after extensive attempts, what are our options? Should we still apply though we know we cannot meet CR criteria? This is only for our own residents who are positive, not outside admits that are COVID positive.
Well, I think that, that's an individual facility decision whether to go ahead and attempt to apply even though you know you can't meet the criteria. And I would base some of that decision on how far you are off from meeting the criteria. If it's a physical plant structure only, if you identify how you are going to meet safety, infection control precautions, et cetera, you might go ahead. I can't really recommend that you do or you don't go ahead, apply. It's possible that you could apply and be denied. But again, as I said in the earlier response, there could be some situations if you are not a COVID relief facility, that you have no alternative but to serve those residents there. But I think that making sure that you document all of your appropriate actions, whether or not you apply, you might have a risk of being denied, but if you want to retain your own residents, you might want a shot.
Do you know how they will verify for the staffing requirement for the CR?
I don't know that they're going to verify it. You have to have, I think, well, for a CR, except new admissions, you do have to have a star rating, so I'm sure they're going to be looking at that. If you're not accepting new residents, they just expect that you have a staffing piece that's appropriate to the number of residents that's in that unit, and they have to be dedicated staff. I didn't get through the application to see what questions they ask about that, if any. I don't know that they can verify it. I think that most of their approvals are going to be kind of like a desk review and virtual. So I think that at this point they're going to trust that you have the staffing requirements that you say you do. I don't think they're going to. I don't think that they're going to ask for. They're not going to monitor anything else. I don't think they might ask for a staffing pattern, but I'm not sure what's in the application at that point because it was too far into it and I couldn't get all of the data. Hopefully, someone who's gone through it might have more information about what's in the applications in terms of that. But I don't think they're going to be monitoring your staffing levels on a daily basis or anything.
CR, does retain mean anyone within our system, such as independent living, assisted living within our campuses?
Well, that's a good question. It has not come up. I would assume that it does not mean that, but there are CCRCs with persons that should stay on campus. That's a question I think that we can put forward to the state and see what they say. That's the first time that question's come up.
Can we have a CR dedicated unit in our HFA areas?
Well, I think that you can. There's no process for you to get approval for it. I don't know that you can, there'd be some consideration. I guess I don't understand what the scenario is. Do you expect just to move your assisted living level persons to that unit as needed? You can certainly do that. There is no reason why you can't, because there are no requirements at all about mandating that or not allowing it. You must ensure as a licensed HFA or even AFC that you are meeting the needs of your residents. So as long as you're using all of the right safety precautions, you could use this criteria to set up your unit as well. There's nothing to preclude that. And in fact, there is some talk on the west side of the state to maybe develop a unit that is designated for this level of care for residents who are also COVID positive.
Will there be an on-site survey to gain approval for the CR units, or will it be granted from the application with a possible inspection later?
Right now, they anticipate that the approval process will be virtual. They might call you. They will be looking at your documents. I think it's more like a desk review. And they're going to send you an approval via email. I don't know that they're going to interact with you directly unless they have questions. And I didn't see anything anywhere about on-site visits.
Someone just said, yes, there is an on-site survey. It takes like 1 hour.
Okay. I'll follow up on that then. I didn't see anything in the guidance that says that. I did see that they intended in the guidance that most of the approvals would be using a virtual format, but I'll look into that further.
When would a resident need to go to a CRC versus a CR? This part is confusing.
Well, the CRCs, the Care and Recovery Centers, are really designed to ensure that there is a place for people that is secure and safe in terms of infection control, that allows the facility to, allows the hospitals rather, to make sure that there is a good discharge placement for their patients who need to move out of the hospital. And also the CRC is designed to serve residents who might not be able to be served in other nursing home facilities. But CRCs and actually CRFs, both of them are designed to serve the nursing home level of care resident. That is a challenge as we move forward, because we know that there's a few or little options for assisted living level residents, and that's something that we're arguing about with the department on an ongoing basis. But the CRC is meant to ensure that the hospitals have a place to place someone, and that if you are a nursing facility and have no means to safely care for someone, there is a place to do that. The COVID recovery facility is simply what we would have called a nursing home with a dedicated unit in the past. What that is for is to allow nursing homes to continue serving their own residents if they get approval, and to make sure that there's some safety precautions and a level of quality going to those residents if they choose to retain them. And additionally, the department wanted to ensure that facilities who felt that they could safely serve new admissions, and in fact they might be dependent on new admissions to keep up their revenue streams, and at the same time serving COVID positive persons in an appropriate way, that they had some possibilities there as well. But they want to make sure that the COVID, that the care and recovery services are used. They're paying a lot of money to keep those facilities up and running. Therefore, you will see a preference for use for new admissions to those care and recovery centers. But at the same time, we anticipate that they're mostly going to be full most of the time, and that facilities will be able to both either retain their own residents or accept some new admissions that might be coming out of the hospitals, with the idea and understanding also that a lot of the hospitals have reduced their elective admissions at this point as well. And so for the time being, you might only be getting COVID positive resident referrals.
I heard Director Massey say yesterday at a meeting that HFA and AFC homes should shelter a COVID resident in a place in a private room using transmission-based precautions. Our HFA, AFC members may want to know this. There is no mandate to transfer that, it seems, as of now.
That's right. Not only is there no mandate, you would have to get an exception to do that, to transfer them elsewhere. And if you refer to the HFA and AFC's FAQs, it identifies the basic expectations for a facility to serve COVID positive residents, to place them in a positive room, use appropriate PPE, and the department does have PPE and transmission-based guideline standards for COVID positive persons in HFAs and AFCs as well, and we've discussed that guidance earlier. But yes, it's like the world has turned around a little bit. Nursing facilities also no longer have to try to have a dedicated unit. This gives you the option to serve or not serve, and HFAs and AFCs can do the same along with that. But part of the dilemma is that there isn't going to be a lot of places to move positive residents out of HFAs and AFCs. So we would encourage everyone to look into that and have a plan on how they intend to serve them, these kinds of patients, if they don't already.
What does as soon as practicable mean? We are looking at situations where we cannot meet the dedicated staffing requirement for CR status, but also have no options for discharge for several residents.
Well, I anticipate, and I think that we all have anticipated that as the COVID transmission rate rises, there's going to be fewer and fewer options for some of these transfers. And as soon as practicable, I mean, to me, obviously, if there's no place to put them, it's never going to be practicable. It means that you need to be searching for a place, attending to the fact that you should be moving these people to a more structured unit, perhaps, that can do some dedicated staffing. But if you can't make that happen, again, you need to document that clearly. Let your local health department, healthcare coalition know, let the department know. But if there is no good, safe discharge place, even the CMS rules would support the fact that you can't discharge that person or transfer them.
If a facility is a 1-star, can they retain existing COVID positive residents as long as they apply to be a CR and don't choose to admit further COVID positive patients?
I think that you could probably retain them for a while. I'm not sure what would happen if the department comes back with with not approving you, and then you're going to have to work with them or work with whoever you can find in terms of CRCs to transfer those residents. I'm not sure how stringent they're going to be with meeting absolutely all the criteria. Excuse me. Some of it may indeed be based on what they can possibly do with the number of residents who are COVID positive that are rising. So again, based on those situations and considerations for the number of persons and the transmission rate going up, they might allow you to be included as a CR because they have that ability. But out of the gate, I'm not sure how strongly or strictly they're going to apply all that. But I would apply if you think that's your best option.
Once again, there is no support or guidance for HFAs, AFCs, and assisted living communities. If nursing homes are not allowed to readmit positive residents without a CR designation, what are ALs supposed to do? This seems to be setting ALs up for major outbreaks.
Well, we have always recognized that it seems like HFAs and AFCs, which would perhaps be a little bit less prepared for the strict isolation requirements that a COVID person would need, also had no options in terms of moving residents as needed. We do know some facilities have set up really dedicated units very well, and others it's simply beyond their, ability. I don't know if that actually sets you up, but there are considerations about if indeed you're having a major outbreak in your facility and cannot manage those. There is no question you should be talking to your local health department and the state. I think that they would realize, based on their resources and capabilities, you are going to need some help in managing. I do know there's a couple nursing homes that have had major outbreaks in the last few weeks. And looking at the HFA AFC numbers, we do know that outbreaks are occurring there. So, that is something that the department, I believe, will pay close attention to. Part of the dilemma is that they just simply have no mechanism and no resources to serve that level of person. And one of the reasons why they're not going to the CRCs is because, number one, they're trying to hold those beds for nursing home level of care people, discharges from the hospital, keep the hospital open. And there's a funding issue with HFAs and AFC residents. Who's going to pay for care in an alternate facility, and how is that going to work? And that's been some of the dilemmas that the department has faced over time. Not that that's an excuse, but we do understand that there's limited options for HFAs and AFCs, and for those facilities that feel themselves in the middle of a huge dilemma, we think should contact the state and contact their local health department for assistance.
What is the most current information to follow for when staff return to work after testing positive for COVID?
If you're talking about the criteria for discontinuing transmission-based precautions, you have to have an improvement in symptoms, no fever without meds for 24 hours, and you have to be 10 days following onset of symptoms if you were symptomatic. If you were asymptomatic, obviously you have to remain asymptomatic through that recovery period. It's simply 10 days from the time of the test, if that's what you're asking, I assume.
When we do POC testing on an approved compassionate care visitor and it's negative, is that result good for 72 hours as if they were tested outside the facility and it would be good for 72 hours? Or do we need to do the POC swabbing at each and every entry?
No, I would not do the POC swabbing at each and every entry. The requirement is simply that they have to be tested within the past 72 hours. So if they are coming in daily, I would make sure that whenever they're coming in, as long as you've tested them within the past 72 hours, you should be good to go.
They do plan to have surveyors routinely visit the building for those with the CRC designation. We applied and had our visit already.
Wow, okay, all right, well, thank you.
They also said the CRC designation is only for SNF, not HFA.
Right.
Can you please repeat where to find the guidance for housing a positive COVID resident in an AFC HFA?
It's the HFA AFC FAQs. And actually, if you just Google HFA AFC's LAURA or FAQs, it'll usually take you right to that website. They haven't been updated, I think, since early October, maybe mid-October. But they have always had some discussion about how to respond to COVID positive residents. And of course, the CDC has recommendations as well for assisted living level facilities.
It is my understanding for POC PCR facility testing purposes, we are allowed to wear one gown and change just gloves, wash hands between each test. Does the same standard allow for staff to drop off meal trays in each rooms, or do they need to change a gown each time they enter a new room?
I'll respond to that separately. That's a complicated question that my brain can't get it. I can't get my head around that one. I will respond to that separately.
Okay. Requiring more paperwork and more hoops to simply care for our residents doesn't fit with prioritizing residents' needs in the middle of the pandemic and takes valuable resources away from resident care. I know Leading Age Michigan is working hard to advocate for us. Please continue to express this concern to MDHHS and Laura.
We certainly understand that. And in fact, as I went through the requirements, I thought that it was just one more hoop to jump through, that I didn't think that and this is just me personally speaking, that I didn't think that there was much impact going to happen here. The problem with this is really that it was a mediating response to some major legislators' concerns about putting any COVID at all positive persons in to nursing homes. And in fact, there was a lot of testimony about that over the last 6 months, some of which was pretty testy. So we do understand that this is another hoop to jump through, and that in reality, I don't think it's going to change much. It's not going to change your options to move people much. I don't think there's going to be a lot of capacity out there in terms of these CRCs. They're still having a hard time getting applications, so that isn't going to be a relief mechanism for you. And for you to serve your own residents, the criteria, while there are some, pieces there that you have to meet, the dedicated staff one is the one that's going to be hardest. It really doesn't change how you're going to care for these residents in any meaningful way. And I'm going on a bit too long about this, but we felt that as well. But at the same time, we had to congratulate the department on trying to make this work based on a law that was originally meant to be very, very stringent about who could come in a nursing home.
We were trained by ID at Spectrum Health to not change gowns when delivering meals unless we have to interact with the residents.
Right. That would be my understanding as well.
All right. So as of now, it does look like that was the last question. So if anybody does think of anything after this webinar has concluded, I don't believe we have the slide today, but feel free to shoot the email off to either dalton@leadingagemi.org. You can also email Deanna@leadingagemi or safeandcalm@leadingagemi.org. So right now we would like to thank Deanna, and we would also like to thank the 100 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. As of now, our next Safe and Calm webinar is scheduled for this upcoming Friday at 11 a.m. Eastern Standard Time. So we will see you all then. And it looks like someone actually just asked if I could repeat that last statement, so I will do that really quick. They said, we were trained by ID at Spectrum Health to not change gowns when delivering meals unless we have to interact with the residents. So I believe that takes care of everything, and I hope everyone has a great remainder of their Wednesday, and we will talk to you all on Friday. Thank you and have a great day.
Have a good afternoon, everyone.